countdown, we can start.
Yes, sir. We're live in 5, 4, 3, 2, 1.
Greetings and good evening to all of you. Thanks for joining us in this very interesting webinar. This is the third webinar in the osteotomy around the knee series, wherein we will be focused on the patellofemoral joint. And hopefully by the end of it, you would start thinking of patellofemoral surgeries beyond the MPFL. To kickstart this program, I would first request President of SCI, Dr. Ashok Rajgopal, to give his welcome address.
Thank you, Parag. Thank you, Raju, and thank you, Parag, for continuing this fascinating series of osteotomies. Of the two previous sessions that we've had, I think a fair comment is a lot of people are familiar with it and have indulged in those osteotomies. This particular session on patellofemoral osteotomies is particularly fascinating because I think it's a rather confusing subject in the minds of a lot of people. It's a little bit like managing chondromalacia. Do you do anything? Do you do anything to the patella? Do you do something to the femur? Do you do something to the tibial tubercle? And we have an extremely experienced panel. I'd like to welcome Ronald, Clement, Bhushan, Raju, and Parag. And I'm sure the deliberations, as in the previous two sessions, will be very robust, and I would encourage all of you to put your questions to the panel and certainly learn from their experiences. So with that, I'd like to hand it back to Raju and then on to Parag. Thank you.
Thank you so much, sir. I'd now request Dr. Parag, the Joint Secretary of SCI, to share a few words on the introduction and the flow of the program.
Thank you, Raju. Good evening, everybody, and good afternoon to Dr. Heerwarden. It's indeed a great pleasure to be here today for the the third osteotomy webinar, and this is going to be an interesting one, which is going to be on patellofemoral instability. I completely agree with Rajgopal sir, as he said that the proximal tibial osteotomy is the distal femoral we are more conversant with, but this is something which very few orthopedic surgeons, arthroscopy, knee surgeons do. It will be very interesting to hear from the masters whom we have today. Dr. Ronald, Dr. Bhushan, Dr. Clement, Raghbir will be joining very soon, and understand from them the nuances of these osteotomies, because I think a lot of planning is required, and you've got to understand, when do we correct in the axial plane, the coronal plane, and unless you really read the x-rays, the MRIs and the CT scans well, we are not going to be able to perform the osteotomy however good surgically we might be. So I think today is the day where we are going to learn from the masters. So thank you, Dr. Ronald, for joining. I know it's a Sunday afternoon for you. You would have been happy to be in a beer garden, but thank you for spending time with us. I really appreciate that. Bhushan, you've just come back from UK. Thank you. And Clement, we look forward to hearing pearls of wisdom from you and Dr. Ronald and Bhushan also. So over to Raju again to continue the proceedings. Thank you very much. And thank you, Rajgopal sir, for joining in.
Thank you so much, Dr. Parag. So without further ado, we start our scientific program. I would like to first invite my dear friend Bhushan Sabnis. Dr. Bhushan Sabnis, as we know, is a complex knee surgeon based out of Mumbai at the SportsMed Mumbai. He does a fair amount of osteotomy work. He will be speaking to us on the need for coronal plane corrections in patellofemoral instability. Bhushan, the screen is all yours.
Just give me 1 second.
Yeah. And just a few housekeeping announcements. Maybe we can have 1 or 2 questions after each talk. So you could please kindly input them in the chat box. I will be monitoring the chat box, and a lot of us will be monitoring it, and we will relay your questions to the speaker.
Let's try and share my screen.
We have it with us.
Okay. So hi all.
Okay.
So let's just start with a bit about patellar instability and the role of coronal plane corrections. So we can think of the patella as a rising sun in the valley in the trochlea as such, and that is a good analogy because it will all make sense as we change the anatomy of the valley or the position of the sun to get it perfectly aligned, to get the perfect picture. So that's what we are planning to do. Now, there's a lot of discussion about the patellofemoral joint and how to get it stabilized. The analogy has been used as a train over tracks or as a suspension bridge, but it's all a game of bony and soft tissue alignment or malalignment, which leads to a recurrent patellar instability as such. Now, if you think of the trochlea as the rails and the patella as a train, it has to be perfectly aligned to run properly. But if you have a trochlea like this, of course, we need to correct this first. And that's what's been touted as the new thing, or that's what has been described as the real thing, to get the trochlea under the patella and not try and move the patella to come over the trochlea. So that's where we need to correct the cause of the problem. Normally, it's usually a combination of factors which lead to recurrent patellar instability. There'll be trochlear abnormalities and patellar abnormalities. There'll be problem with the framework. That means there'll be alignment issues, rotation issues, patellar height issues. There will be problems with the support such as MPFL and VMO. And there are other problems such as syndromic or hypermobile patients as such. So we need to solve the problem and come to the solution and not treat the effect. So what I feel is MPFL rupture is the effect of instability. So just doing MPFL without treating the cause of occurrence of MPFL rupture, unless it's a purely traumatic injury, will not solve your problem, and your MPFL reconstruction will fail in a few years' time. Of course, we are way ahead of this now. We don't do just lateral reefs and medial reefing. Having said that, it's sad to see a lot of patients coming with this done just last year or 6 months back and having failed again. Now, of course, eye-catching picture for all of you. What we are looking at is concentrate on the legs here, guys. So we are looking at the alignment of the tibiofemoral joint when you're talking of coronal plane alignment. Now, for a patellofemoral joint, valgus is bad and varus is all right. Now, that's a good evening gown, I agree, but the Q angle here is quite significant. So every time the quadriceps contracts, the patella has a tendency to go outside. Now, there are a lot of things which have been discussed about treatment options. The key thing here is to correct the problem. So find the problem and correct the problem. There is, of course, a zone of acceptable malalignment, which can be accepted, and not every patient will need a derotation osteotomy. But it's important to have a formal algorithm in your mind. And this is a very good paper if anyone is interested from Faris Haddad about the algorithm of management of patellar instability. Now, this is what I generally follow in terms of managing osseous anatomy problems. I've skipped the ligamentous issue, so we'll just directly go to the osseous alignment issues. So the first thing you look for is the alignment or the rotation issues. Now, if there is a mal-rotation beyond 20 degrees of distal femur, that means there is more than 20 degrees of intorsion of distal femur, then I think we should think of a derotation osteotomy. Any valgus, and I mean any valgus in the recurrent dislocation of patella, which is more than 5 degrees, I would not hesitate in adding a realignment osteotomy to correct the deformity. Of course, we know about trochleoplasty. We are going to hear a lot about it. And of course, the patella height, whether it is patella alta or baja, and that need to be corrected. You can distalize or proximalize a tibial tubercle based on the kind of deformity you have and what you are dealing with. Today, we're just going to talk about an osteotomy for correcting the coronal plane alignment. Now, there's slight difference in a real tibial extorsion causing, or femoral intorsion tibial extorsion, which is causing an increased Q angle, and a genuine genu valgum. I think whenever there is a genuine genu valgum, you need to correct the tibiofemoral alignment rather than just doing a tibial tubercle osteotomy, because that's the only way to correct the tracking perfectly for this. Now, there is a different protocol for managing this in pediatric population. We do get a lot of pediatric patients who are growing at the age of 13 or 14 when they still have one growth spurt left. You can do something like this, where you are modulating the growth by doing a temporary epiphysiodesis, and then you can achieve a perfect alignment, and the recurrent dislocation of patella usually is sorted. When they are adult, you can of course do a osteotomy, as you can see here. This is a classical picture when you do an arthroscopy that the patella is sitting way on the lateral side and you need to correct it. Now we are talking of a DFO today, so we are talking of a varus producing or varising DFO. You can do a lateral opening wedge or a medial closing wedge. The normal practice is to go for a medial closing wedge, for it's much more stable generally without any issues of healing problems, and approach is pretty easy as such. And there are a lot of papers to support it. This is from 26, sorry, this is the latest one that I could find. It's a very good paper from China talking about a closing wedge medial DFO plus minus MPFL reconstruction to stabilize the patella. Another one from 2018, it's a good paper talking about whether just a DFO is sufficient, and they found that in about 11 patients, just plain DFO was enough to get the stability in a patellofemoral joint. And indeed, whenever you're doing a DFO, the moment you correct the valgus and get the knee neutral, the patella stabilizes. MPFL is just a supernumerary Chekrin ligament that you add after doing the osteotomy as such. A 36-year-old lady who had a fall last year, which was supposedly a first episode, but she always had issues with her patellofemoral joint. So she has lateral knee pain as well as patellofemoral instability. And what you need to do is plan it properly to see what kind of correction you're planning to achieve for her, and do a medial closing wedge osteotomy such as this to get the leg perfectly neutral. And this normally solves the problem. So we're not only talking of instability, we're also talking of patellofemoral pain as an issue, because a mal-tracking patella will always be a painful patella, painful patellofemoral joint, I mean. And doing this gives them immense relief, and that will be a practice, that will be something you'll see in your practice pretty routinely. I normally do much smaller incision than this, but this is a standard approach for a medial osteotomy, medial DFO. You see the vastus medialis and you lift it up to see the femoral shaft. Now, we normally do a biplanar osteotomy so that you won't violate the patellofemoral joint, such as this, and then you take out the wedge as you normally take. So that's how it looks on the X-ray. You can see a nice wedge coming out here. The hinge point is normally just at the level of supracondylar ridge on the lateral side. Unfortunately, risk of hinge fracture is quite high, and you need to be very careful when you're closing it. You of course blame the assistant when it cracks, that he's done it too fast, but essentially what you need to do is you take the control of the situation and slowly compress it, not varise the distal leg. All you need to do is just squeeze the leg into the femur. So you just compress it tight while you are weakening the osteotomy using a K-wire or your saw, whatever your preference is. And then usually speaking, you won't have a hinge fracture, and you can get a brilliant fixation without breaking the osteotomy on the lateral side. Power. So that's a big wedge taken off, but even this wedge can be, this osteotomy can also be closed without having any major issues as such. So when do you think of a lateral distal femoral osteotomy? Whenever you are adding a derotation component. Now, all of these patients will have some contribution by a femoral intorsion, and you will want to do a derotation at the same time as well. There will be a group of patients where there is shortening on the ipsilateral side, and in such patients it's wiser to do an opening wedge osteotomy than a closing wedge osteotomy. And these are the two standard indications where I would go for a lateral distal opening femoral osteotomy. It looks something like this. It's exactly similar to your normal HTO on the tibial side. And funnily enough, the medial side of the femur has a thick meshwork of ligament and muscular attachment. So if you remember the medial anatomy, you'll remember the gastroc tubercle, the adductor tubercle, and the medial epicondyal attachment, which is all somewhere in this region where the hinge point is. So there's decent support to the osteotomy, and you can indeed safely open the osteotomy without having any issues as such. So you can use a peak plate or a standard plate, whatever way you want to correct. But I think this is a first step that you want to do anytime you want to stabilize the patella. This patient was arthritic as well as patellofemoral pain issues, and did really well. Refused to have a scanogram because she said, I don't want to spend any more on getting x-rays. I'm quite comfortable just now. So I just extrapolated the x-ray here, and you can see the change in the alignment as such. Now, Ronald is going to speak a lot about this, but whenever you're doing a derotation, what you can do is you can use the biplane from the derotation osteotomy and use it to valgize. So you need to use it to varise the femur so that it looks something like this. If you look at this X-ray, you can see the opening that you have achieved on the lateral side, which will allow the leg to be varized. That means you are achieving two things. You're killing two birds with one stone by doing this osteotomy as such. So just to cut things short, I think you need to get the sunrise perfectly in there by doing whatever you need to do. If there is a valgus deformity, that will need to be addressed first. So bony surgery always is done first before you think of doing anything more. Quite a few times I combine a varizing DFO along with a tibial tubercle distalization for patella alta, and I always add an MPFL to it because I think that's a good Chekrian ligament which stops the patella from subluxing ever. Thank you.
Thank you so much, Bhushan. That was a wonderful talk. And one key message that I took from your talk was to do an axial compression to close a medial DFO. Most of us have this knee-jerk tendency of applying a lot of force. And as you correctly said, always the assistant is at fault. I'd like to welcome Dr. Raghbir. Khakha has just joined us. Raghbir, good to see you, and we'll have your active participation in the discussions later on. Bhushan, I'd like to start off the questions. You mentioned in your talk that there is a zone of acceptable malalignment that you are willing to tolerate. What is that zone in your practice, and when do you decide to combine this DFO with an MPFL in a situation where the patella is unstable?
So I think I always do an MPFL reconstruction with a DFO for any patella instability. I think MPFL is a Chekrian ligament, and that has to be, in my opinion, of course, that has to be done for any correction you're doing. So whether it be DFO, whether it be trochleoplasty, or whether tibial tubercle transfer, you add the MPFL along with it because that's the last straw to go. So that's the last thing to break when a patella dislocates. So I think we need to put a MPFL in every time. That's just my thinking. Apart from that, regards to zone of acceptable malalignment, if you look at the rotation of the distal femur, if it's between, let's say, 0 to 20 degrees, I won't change that. If valgus is around 5 to 6 degrees, I won't try and change that much. So these are the sort of things like your TTTG distance between 15 and 20 is what you call the gray area. Over 20, you always correct. So these are the zones of acceptable malalignment. Of course, the other side needs to be seen as well. So if someone has knock knees on both sides, just immediately varizing one side may not be appreciated by the patient because of the cosmetic issues that he or she might have. So I think these are the things you need to look at and individualize your treatment based on your patient.
I'd welcome any other questions that the panel members may have, and I think we don't have any as yet in the chat box. I think the audience is just warming up. I'd again encourage the audience to be active and discuss this. So anybody in the panel would like to have any question asked to Bhushan? Otherwise, we move on to the next talk. Right. So I think we can have more discussions with Bhushan, and Bhushan himself will be moderating the panel discussion. It is my great pleasure to welcome our next speaker, whose professional reputation needs no introduction thanks to his staggering professional reputation, Dr. Ronald Van Heerwarden. We all know that he's a very accomplished osteotomy surgeon. He presently practices at Harley Street Specialist Clinics in London and the London Osteotomy Clinic. He was previously practicing in Dubai. He formerly headed the Limb Reconstruction Center at St. Martin's, Netherlands until 2016. He is very academic with multiple book chapters, multiple publications, a member of the AO expert group, the past chairman of the ESCA Osteotomy Committee, and I believe the current vice chairman of the ESCA Osteotomy Committee. Thank you very much, Dr. Ronald, for accepting our invitations. And we invite you to speak on axial plane corrections and patellofemoral instability.
Thank you so much for the great introduction, and also for having me here in this interesting session, because patellofemoral joint instability is something we all see in our patients wherever you are in the world. And to that extent, I hope to give you some more information you can work with if you're dealing with patients who have axial plane deformities. Now, let's have a look. First of all, my disclosures. And then let's have a look at this picture. I think if you take this picture from my presentation of today, it's the most important picture here. And that chapter, if you can find that chapter in Frank Noy's great book on knee disorders, published in 2010, on the Bob Taichi chapter on patellofemoral, it's just a great chapter. Now, if you look at the picture, the inward twisting of the femur causes the patella to go lateral. Then the external torsion of the tibia also causes that your Q angle increases, and also causes that your tuberosity moves outward in many of these cases, and also causes that the patella wants to go outward. And what we see in these patients is this inward pointing knee. And that's a specific feature I will show you in a couple of patients. Now, from this, how does it work? A femur inward femoral antitorsion and the inward pointing knee. Well, the hip just wants to have a position of 15 degrees anterior when you walk and during stance. So if you have an anteverted hip, like in the patient walking over there, the hip wants to rotate backwards, and by that, the knee points inwards. And that's just the case in all these patients. Well, in the patient in the video, you also see external torsion of the tibiae on both sides. So she has a miserable malalignment, femoral as well as tibial deformities. And this is the femoral deformity with the knee pointing inwards. So what does that cause to the patella? This is a transverse slide from the same chapter again to show that. With the inward twisting of the knee, the compression increases, you have a tension increase, and you have a moving lateral of that patella. So the femur inward femoral antitorsion, an inward twisting of the knee, and the patella and the stretching of the medial stabilizing structures, that causes a patellar instability and patellar subluxations and luxations. That's the cause when you have a rotational deformity in the femur. Now, there is literature, and there's an abundance of literature coming out in the past 5 years. And many of that comes from Germany, but there are also from all around the world other good publications you can find. And they all confirm this. The increased internal femoral torsion can be regarded as a risk factor. And also, to come back to the previous speaker, Bhushan, on the MPFL reconstruction, the MPFL will just fail. The bone always wins. So if you are putting an MPFL in a patella at the right height, but there is a femoral antitorsion underneath that, the trochlea position is not normal, and there are huge stresses on your new MPFL, which you made, and that may be a perfect MPFL reconstruction, but it will fail in the end, and particularly if you have a double level rotational deformity. So always check for that. How do we check that? Look at the rotational profile, this one on the right side. This is from Stahaley. You look at the gait, you look at the foot progression angle in gait, you look at the hip rotations, and you look at the thigh foot angle. And of course, you have extreme patients like this patient from the Abu Dhabi practice who can do this. Well, I wouldn't advise if you have patellofemoral complaints to do that, but these cases are there, and they come not so much with gait abnormalities because they compensate in their hips, but they come with the patellofemoral complaints. And these complaints can be huge. So on the right, or here you see the rotational profile, extreme internal rotation, no external rotation whatsoever possible in these hips, and the foot position is normal with great banana socks in this young girl. Now look at this patient. She has a different rotational deformity. Look at her walking. It looks like valgus, but actually it isn't valgus. Why is she walking like that? Look at where the knee is moving, extremely inwardly pointing knee. And again, there is no valgus. This is her leg alignment view. What does she have? Again, the rotational profile, and that takes only 10 to 20 seconds in your outpatient clinic, just checking up their prone position, rotations of the hip, normal. They go over the midline, and look at the foot position. She has an external tibial torsion as a deformity. And again, severe patellofemoral instability complaints. We will see her back later in the presentation. Now, what are the normal values? And of course, you have to look at it also in growth. At birth, femoral anteversion may be, in most of the people, 40 degrees. 10-year-olds have like 24 degrees, and then right after that, in female, like at the 12th year, in male it may be extending to 15 years maximum, they reach the adult value of 10 to 20 degrees. Tibia version, they all have internal torsion at birth. Look at these young toddlers walking, feet pointing inwards. At 10 years old, already 10 degrees external torsion, and in adults, 20 to 25 degrees of external torsion. So that's normal. There are differences around the world, but the differences are not too big. So out of that, already in 2003, we wrote a study on the derotation osteotomy for correction for congenital rotational lower limb malalignment. And these are the normal anatomy, the rotational deformities defined, and my operative indications. And Bhushan was already mentioning it. When your rotation in the tibia is above 2 standard deviations, 35 degrees, I would consider doing a tibial rotation correction. If the femur torsion is above 20 to 25 degrees, I would consider doing a femoral derotation osteotomy. And there is debate on these values, and you may have higher numbers before you start doing the surgeries. I've been doing this surgery for rotational correction since the early 2000s, and I am not lowering these limits, but I'm for sure not giving the patients higher values because I know it works. These surgeries work. Now look at growth. This is 2.5 years old. Abnormal rotational profile. We're looking at femoral anti-torsion, and this is at age 12, and there it's corrected. So 90 degrees of antetorta have a spontaneous correction before the age of the 9th year. How do we analyze this? If you are not in the position or in the environment where you can make CT scans, the femoral deformities you still can analyze with X-rays, the done views. But the golden standard these days are CT scans. And if possible, send your patient to a CT scan facility, have these standardized CT scan slides, which you can compare to each other, and then relative values proximal to distal in the femur as well as the tibia. There you make your angular measurements. And there is discussion on that too, the height and the accuracy, but make your own system from, of course, Weidelich, for example, one of the standard references, but in your department with your CT scan facility, you need to have your standard and make your measurements, and then it's accurate. Now, there is a lot of literature these days on the complexity of the bony malalignment, and it's very interesting to read this literature. However, there are new things discovered and new things defined where, to be honest, I don't have a clue yet how to treat that. There is a new thing going on in the literature on knee torsion. So torsion within the knee joint and the axial engagement index of that patellofemoral joint. Well, if I have to think about doing an osteotomy for a rotational deformity, which is localized only in the knee joint itself, that will be a difficult osteotomy. Anyhow, we will see in the next years what comes from this, but you can find through PubMed or Google Scholar, you can find a lot of very recent articles on deformity correction and the deformities that cause patellofemoral instability, and that deformity is in the rotational plane. These are old slides. This is from the publication we made in 2003 already, and it has been repeated in some of our books. And it's just looking logically at the level of the proximal tibia osteotomy. You can make a tuberosity, you can make a cut above the tuberosity, but when you then rotate the foot and the lower leg, the tuberosity will also rotate with it. And that can be something you want to do. If you don't want to do that, you can make a cut below the tuberosity, or you can do a biplanar cut. The third option from left is a biplanar cut where you rotate on purpose the tuberosity, and the fourth one from left is a biplanar cut with a distal tuberosity cut, and you will not rotate the tuberosity, and you leave the patella tracking unharmed. So, and the fifth option is if the TTTG is very far off and will not correspond to the rotation angle, and I will come to that in the next slide, then you make a separate tuberosity osteotomy and you translate the tuberosity or you refixate it. Now, there's also literature on that and also on the accuracy of measurements on that, even with PSI guides these days, where you can do a combined tuberosity translation and a rotation in one cut. This is a rule of thumb measure. So if you look at a supratuberosity osteotomy and you rotate the foot and ankle inwardly from an external torsion position, in a normal diameter tibia, a 20 degrees internally rotating osteotomy with the tuberosity will produce a tuberosity medialization of 7 millimeters. So if you do 15 degrees, you will medialize 5 to 6 millimeters. So, and from that, you can just find a rule of thumb measurement that you can easily translate the tuberosity to within a normal value, a normal range, which you aim for when you do a rotation osteotomy. Also in this area, there have been very nice recent publications also in the American Journal of Sports Medicine. And these are very complex measurements. However, we come to the kind of the same values in the end. Now, these are my surgical tools. You can use for rotational corrections, you can use these angles, who are from the AO set, K wires, of course. And then I have a special rotation tracker I'd like to work with, but these angles also work fine. Or you can sterilize or have a sterile tracker. These plastic things also in your hands can work perfectly. Now, you can do rotations on the proximal femoral level, the intertrochanteric osteotomy with blade plate fixation. These work. The blade plates can still be used, and you can just do it the old-fashioned way, AO, and you can do your femoral rotation osteotomy. I'd prefer to do it in the distal femur, and I will show you that technique, but this is still very valuable, and especially when you also want to do a varization or valgization in that hip area. Now here we go for the distal femoral osteotomy. And here you see in the video, the step-by-step. I'd like to go from the lateral side and under fluoroscopic control, a transverse cut Bhushan has shown the excellent technique he uses, the biplanar technique, where he also likes to varicize. I'd like to do a uniplanar technique. This is after rotation correction, external torsion, external rotation for internal torsion, plate fixation, and this is then how it looks like at the end of surgery. And these surgeries I'd like to perform not mini invasive. If you're a master in that, of course you can do that. My patients do not ask for that, and I'd like to have a clear view to make a safe surgery there. Now, you can also do femoral rotations, of course, and in the shaft area, and this is such a case. And there's that rotation tracker, because all the implants and the plate needed to go out. We did a shaft correction in this patient, and it healed up nicely. And then you have a much better position of the foot and knee afterwards. Torsion malalignment, you can do double level rotations at the same surgery, or you can do it step by step, do the femur first and then do the tibia at second stage. It's just a choice. In a experienced team, this does not take more than like 60 to 90 minutes to perform safe surgeries on the femur and the tibia. This is medial plate fixation. You can also do a lateral plate fixator as I showed in the previous video. Now, we come back to this patient, and she was kind of told that she had valgus, and she was sent to me for a valgus correction into neutral. So a varisation osteotomy. But immediately, having the knowledge you have been given now, you see that she has a kneeing in walking pattern. And again, it doesn't surprise that she has a neutral leg alignment. And this is a rotation profile again. It's all in the tibia. So what do? This is a surgery in my hands with my experienced team, which takes 35 to 40 minutes. This is an infratuberosity rotation osteotomy. I put an extra staple in. Doesn't take much more than that. And this is like 3 months afterwards, the full bone healing, and it may heal as fast as in 6 weeks already, and they are full weight bearing at that time. Now look at her walking then at 3 months post-op. And this patient is at that time like 18 years old. Her complaint started at 12 years age. I told you rotational growth has ended at 12 years of age. She had several doctors, colleagues, not recognizing her rotational deformity. She had numerous house doctor visits. She had a psychiatrist visit because the last orthopedic surgeon 5 years before she visited me told her, it's nothing with your leg, it's all in your head. And we shouldn't do that. Patellofemoral patients may have such a deformity which we can easily treat. She was so happy to be off crutches because she was on crutches for the past 5 years because of that severe patellofemoral instability and pain complaints. And it's just looking at your patient, do a proper examination and find the deformity. And then the surgery, we can all do these surgeries. That's not a problem at all. Let's go to the tibial proximal rotational osteotomy. I'd like to go anterolateral. I'd like to make a cut behind the tuberosity if necessary to do a biplanar rotation. I'd like to prepare it, and you can all find this step by step also in the books. You put your retractor medially in between the bone and the medial collateral structures, of course, and then you do a transverse cut and you rotate distally. And here you see that rotation tracker again, where I check the rotational malalignment at the correction. At the end, I'd like to have a threefold protection against compartment syndrome. Not only I put a non-suction drain, I also leave the fascia open at the proximal side, and I do fasciotomies. And that prevents me from compartment syndromes in these patients. Then you can also do distal derotation. This is a little bit of an old picture. This is post-traumatic, post-nailing of a cruris fracture. Foot is pointing outwards extremely, and there. And these are higher angles than 20 degrees. I'd like to correct in the distal part. And this is just distal derotation with fibular osteotomy. You need to cut the fibula to go beyond 20 degrees distally, in my opinion. And then you can do a safe surgery with some kind of minimal invasive plating. Now look at this patient. 20 ORs, patellofemoral pain and instability, and she's in her 40s at this stage. And she has these complaints since 14 years old. And she remembers there was a doctor who did, at the 3rd or 4th OR, he did something with rotation of the tibia. And now she's walking like this. Look at the foot position. So after these surgeries, there were 16 to follow, all kind of arthroscopic, MPFL, and I don't know how many kind of small soft tissue surgeries she had, but it added up to 20. And if you look at the patient walking like this, of course, that patella tracking is abnormal. This was an overcorrection. So I was happy to do the 21st and the 22nd and the 23rd surgery, and the 23rd was her last hardware removal for both legs. And look at the right lower corner. This is a normalized position of the feet again. And this is her walking at 3 months post-op. And of course, she was not perfect. Of course, she was not totally free of complaints, but walking was much better and pain was reduced, and she had no patellofemoral instability anymore afterwards. So be careful with your rotational corrections. Now here I go fast because of the sake of time through the literature. Anterior knee pain with excess femoral anteversion, hip rotation osteotomy is good results, Bob Taichi, Tunis and Heineke, but also miserable malalignment deformities. It's all in the literature. And again, I told you the recent literature shows great results and new definitions, but also things that can even this part of deformity correction may put forward. There is no surgery without complications. Look at this table also from the 2003 article. Femoral procedures as well as tibial procedures may get nerves stretched and may get temporary neuropathies. Besides, of course, if you are not protecting the tissues well, you can cut these nerves in these rotational corrections. Winding of the nerve is a true pathology. However, I've rarely seen it. And if you just take care of your soft tissues like in normal surgeries, you should be able to prevent this. As a take-home message, check for rotational deformities in these patients with patellofemoral pathology and gait abnormalities. Your consultations start when the patient walks in, and you will find immediately abnormal gait. And put them prone, do the rotational profile. It only takes 20 seconds. Analyze the deformity and plan the correction carefully. Femoral and tibial derotation osteotomy show good results in these patients with patellofemoral instability. Try to find that chapter of Bob Taichi. And if you want to read more of our own group's knowledge on this, you can try to get this article out of 2003 or read the books. I thank you for your attention.
Thank you so much, Dr. Ronald. It was an amazing talk. And the one key message that I took from this talk was to have an age ceiling of 12 years, beyond which rotational deformities are not expected to spontaneously correct. I mean, our pediatric orthopedic training taught us that a certain amount of femoral intoing due to femoral and tibial intorsion will spontaneously correct. It is the external torsion which is the more problematic of the two deformities. Do you use any other objective criteria, Dr. Ronald, apart from the age at 12 to determine that, yes, now the deformity is not likely to correct itself spontaneously and some intervention needs to be done?
Yeah, it's always a combination of factors. Sometimes they present exactly at the age of 12 or just around that age. But many of these patients have gone through years of physiotherapy and other situations. So the whole discussion on the age is beyond that, because even length growth has ceased at that point. But yes, to do these corrections, you'd like to have them at least also at an age where the growth plates are not affected by a correction anymore. I have no other additional measurements I do. Clinical examination, very important here, and a CT scan, and that works for these patients.
I invite further questions from the panel.
Yeah, Raghbir, after you, I go.
Okay, hi Ronald. Amazing talk, and I always pick up something new when I'm listening to your talks. I've got the luxury of working with Ronald, and Ronald, I guess one question that I'm sure the other guys will want to know is, as you said in your talk, the bone always wins. And when these patients come to you with subluxing patellae, anterior knee pain, what percentage do you think of your patients do you end up needing a soft tissue reconstruction on top of the bony correction?
Oh, well, thank you, Rax. Good to see you here, joining us here in the panel. That's difficult. I have no normal practice. I see a lot of referred patients, and I see these patients also at the so many opinion. So it's probably, I'm not the best person to answer that. But in these patients who have had several surgeries before or have been neglected for so many years, the aim at the end of my surgery is to have all factors corrected. And I'd like to add, for example, not a lateral release, but a Z lengthening, so a lengthening of the lateral structures if necessary, if they're very contract. And I'd like to add a medial reefing plasty or MPFL if needed, so that at the end of surgery, everything is covered for. That's the aim of my surgeries. And then, of course, as I'm being sent the deformities in the bone, it means that in quite a high percentage, we do soft tissues to go with that, just to be ready with everything. So that's what I see.
And I think that Z lengthening is a really nice technique, which is sort of under taught and utilized. I gather it was a French surgeon you picked that up from. Is that correct?
Yes.
There's a good publication on that. Yeah.
Yeah.
Thank you, Ronald.
Yeah, I have a question, Ronald. Outstanding talk, like always. Really, a lot of new things for me. One basic question, on the investigations. Of course, the clinical examination is paramount, where you find out, the various rotational versions, deformities. But apart from a CT scan, would you always consider to do an MRI also? And what is your sequence of radiographs? You showed that you took a long leg X-rays. So do you always do just the long leg X-rays, or are there any other plain radiography X-rays which you would advise, and MRI role apart from CT scan?
Excellent questions. MRI, I only use when I suspect that there are cartilage lesions in these patients. Sometimes I use it when there are relatively fresh re-injuries to check upon the soft tissues. But I don't feel comfortable using MRI scans for rotational measurements, to be honest. Then So that to the value of MRI here. Also TTTG measurements, I'd like to measure on bone, that's the CT scan. And there is debate on that, and anyone can question me, but that's how it works for me. Now, of course, there is a long leg X-ray also in these patients, because as Bhushan already mentioned, it's very important to also address if there is valgus beyond like 5 degrees, address that too. Rotate and do an open wedge or closing wedge for that matter to check on that, to also mark that box done. Because if you have additional frontal plane deformities and they're not taken care of, and that's also the sagittal plane, which is not in our talks here, the height of the patella is also something that's very important to address, not only to have a anatomical MPFL reconstruction. You cannot do an anatomical MPFL reconstruction when the patella is high. It's just not working. Bring it to the level where it should be and then do any soft tissue. But so other planes are also addressed in my analysis, as this was only on the rotational, and because of the sake of time, I didn't include it. So I'm very sorry for that.
Can I ask a question, Raju?
Yes, please, Bhushan.
Yes, Ronald, that's a excellent talk as usual. Just one quick one. I'm always it's adult thing, so I can easily say I'm always shitting in my pants when I'm doing a proximal tibial derotation. You're always worried about neurovascular compromise. So what's the limit you would go to, and do you suggest doing monitoring like the spine surgeons do to make sure you don't get a neurodeficit afterwards? Or is there a role for a slow correction using external fixators like Elizarov or Taylor spatial frame if you are beyond, let's say, your comfort zone?
Yeah, this is the specialist question, of course. Yes, but I don't feel comfortable either in all these patients, specifically the post-traumatic patients where you know the nerve and vessels may be scarred down there in the back of the knee. But if you consistently go step by step with your surgery, it's the safest you can be for your patient. My cutoff value, if the deformity in the tibia is reaching 20 degrees, I will not do a proximal derotation. The nerve stretches probably too much, and I feel more comfortable to do a derotation distally above the ankle joint, where I have to cut the fibula also, and of course rehabilitation is different. So cutoff point for me is 20 degrees, and it works for me. I do not need to do a fibula cut if I do a proximal tibial derotation by 20 degrees. I need to do a fibular cut when I do beyond 20 degrees distally. And there are surgeons like Martin Snow, for example, who's a fan of distal rotations. And there are others who have great experience with distal tibial rotations. I think in my population, most of them have less than 20 degrees of rotational malformation in the tibia. So I often go proximal, and some of them are extreme, and then I go distal. So that's how to be safe in my hands. I hope this helps.
Yeah, I have one more question, Ronald. You spoke about proximal femoral intertrochanteric osteotomy versus a distal femoral osteotomy. So what are your indications? When do you decide at what level would you do an osteotomy to correct the deformity? You know, would it be a proximal femur? Well, obviously, I've seen in the talk you're more biased towards the distal femoral osteotomies, but are there any clear-cut indications for either of the osteotomies, proximal femur or the distal femur?
Yeah, well, that's a very interesting one. 99% are distal these days for me. So the proximal only if you want to do a valgization or varization of that hip at the same time. And sometimes, and then I go subtrochanteric, I do a shortening. So you can do an acute shortening osteotomy, cut a segment out, and that's a better level to do that. But 99% is distal. It's far more easy in my hands, it's safer, and I have better control. And these blade plates, There are better versions of plates these days to do the fixation proximally. And if you're a hip surgeon, probably you feel more confident to do that level. But I'm a knee surgeon from origin, so I'd like to do the distal femoral, and it works the same. It's the same bone.
Great. So one last question. The case you showed on the 18-year-old girl, very, very interesting, that tall girl who had symptoms since 12 years. You did an infrapatellar osteotomy for her. So what was the algorithm of the planning? Why not distal femur, or what was the reason? What was your analysis? I didn't quite catch that when you presented the case.
So that was the young lady who was walking, and then I showed the post-operative walking. That was her.
Correct. Yeah. The 18-year-old,
well,
tallish kind of.
She only had. She didn't have an abnormal TDTG. She only had external torsion, but by her extreme kneeing in, that the problem was that everything went unstable. She had it for that many years. Her muscles were not up to it, and she had this valgus kneeing in pattern, which made everything unstable. And she had this patellofemoral instability complaints because of that. So the workup was CT scan. CT scan showed no femoral deformity, as I already said, found in a clinical examination. CT scan showed an isolated tibial deformity and TTTG normal. And together with that full leg X-ray, that was enough for me to go for. And she had, and the knee, of course, the knee pictures show a normal height of the patella. Then I have enough.
Perfect. Thank you so much.
Okay.
So much, Ronald, again for this excellent talk. And I think the audience can take this message that such an experienced surgeon like Dr. Ronald, he openly admitted of feeling slight trepidation while doing these complex derotational osteotomies, particularly concerning the neurovascular bundle. And it is, I think, well advised for all of us to pay heed to his advice. I now take great pleasure in inviting the next speaker, the last didactic talk for this session, and then we'll have the panel discussion. Dr. Clement Joseph from Chennai. He will be speaking on the role of trochleoplasty and a word of patelloplasty on patellofemoral disorders. Clement, over to you, please.
Thanks, Raju, and thanks for the SK Society of Knee Surgeons for this wonderful opportunity. And it's been a learning experience from Dr. Ronald for so many talks. We are very grateful to you. Thank you very much for your nice talk. And let me share my little experience with the trochleoplasty. We all know that the MPFL is an essential lesion which happens in almost all patellar dislocations. Apart from that, one has to be aware of three major bony problems in these patients. The number one, a high riding patella, the patella alta. The number two, trochlear dysplasia, and then increased TTTG distance, which indicates the lateralized tibial tuberosity in these patients. And finally, one should not forget, especially in very difficult cases and syndromic patients, to assess and account for torsional deformities. It is surprising to note that some amount of trochlear dysplasia can be present in up to 85% of these patients, if you look for it actually. And we all know that MPFL guides the patella into trochlea by around 20 to 30 degrees of knee flexion. So the MPFL is important for stability near extension. Where trochlea is important is it accounts for the stability in mid-flexion angles. And when it comes to trochlea, one has to look in two segments, the proximal trochlea. The shape of the proximal trochlea is very important as it can guide the patella into the groove, and then the groove itself, especially the lateral facet, which can give lateral support to the patella as it engages the groove. So in MRI and CT, one should assess both the proximal trochlea. As you can see here, the proximal trochlea is the part where you start seeing the patella in the cuts. So one has to look whether the proximal trochlea is bump in this area, whereas the same patient, you can see the distal trochlea. One can easily see that, say that the shape is normal, there is a good lateral support. So very important to know how the proximal trochlea looks and how the distal trochlea looks. And as long as the sulcus ankle and lateral trochlear inclination are concerned, they describe more of the distal trochlea support. And this is the analogy which I would like to show. And then one should understand reading a proper lateral X-ray and how the different varieties of trochlear dysplasia can show different features on a properly done lateral X-rays of the knee. In a normal trochlea, you can see you have both the anterior femoral condyles are higher than the floor. So you see two shadows. The front one is the anterior femoral condyle, and you can see a similar shadow going up from the Blumenstadt line, which indicates the floor of the groove. They don't cross each other until the anterior femoral cortex. So this is very important. This parallel lines which they never meet indicates a normal shaped trochlea. In case of a shallow trochlea, you can see on the left side, the floor merges with the roof here. And this is reflected as a crossing sign in this X-ray, where you can see the floor, the radiological line depicting the floor crossing and meeting with the anterior femoral condylar line. And the next form of dysplasia could be medial femoral condylar hyperplasia, where the medial femoral condyle is poorly developed and much lower level than the lateral femoral condyle. This will be reflected as two radiological lines, which is shown as a double contour sign. One should look for this sign, which indicates a medial femoral condylar hyperplasia. And then finally, we come across this cliff-like pattern where almost the entire trochlea is composed of lateral and hardly we see any medial femoral condyle here. So this supratrochlear spur or a cliff pattern will be seen as a supratrochlear spur in the X-ray. So these are the typical radiological signs which can be observed in properly done lateral X-rays in different varieties of trochlear dysplasia, based on which we have the de jure classification of type A, B, C, and D. And each type we have specific issues where in type A, there is a decreased lateral support. The proximal entry is good. Once again, on type B, the proximal entry as well as the lateral support is not good. And type C, proximal entry may be okay, but lateral support is not there. And in type D, both proximal entry and lateral support are affected. So MRI can also be used to classify these types of trochlear dysplasias. And we've been ignorant about this a few years back, but even after becoming known about trochlear dysplasia, we've not been treating. Many times we used to do soft tissue surgeries, and we do a partial adoption. Very few cases only we are doing it. Because of technical difficulty, we were worried about cartilage viability and also the possibility of developing osteoarthritis. And now we have plenty of literature evidence to show that this can be done in a safe manner. And we also have excellent instrumentation to perform these procedures. And can we get away with only MPFL reconstruction without doing trochleoplasty in dysplastic trochlea? There are so many studies which shows a poor result when you do MPFL reconstruction in patients who have higher grades of dysplasia. Probably you can get away with the minor grades of dysplasia, but if the trochlear dysplasia is significant, probably you have to consider doing trochleoplasty, especially in patients with type C and type D, rather than doing type A and type B. And what happens in a dysplastic trochlea is in extension, the force to dislocate patella decreases, as well as beyond flexion. Also, we have the patella can be easily dislocated out of groove. So this is very typical of a mid-flexion instability. And a lot of times people, my colleagues are, can we go and do a tibial tuberosity transfer so that we can avoid doing a trochleoplasty? Once again, this is a bowling alley analogy which is given to describe this problem. So it doesn't matter where you're bowling, standing and bowling, as long as the bowling track is spherical like this, your ball is not going to land in the correct thing. So this applies to doing a tibial tuberosity alone in trochlear dysplasia, because as long as the tibia is, patella is not being guided properly by this bump, it's not going to matter where you're going to shift your tibial tuberosity. And one interesting thing with doing trochleoplasty, or when you're creating a new lateralized groove in the trochlea, actually you're reducing the tibial tuberosity trochlear groove distance by shifting the groove laterally rather than shifting the tibial tuberosity medially. So if you're doing a trochleoplasty, the new groove itself can compensate and can reduce the TTTG distance. This is an important thing to consider when you're doing a trochleoplasty. So many cases you can avoid doing a tibial tuberosity transfer itself. So when to do trochleoplasty, the indications would be a severe trochlear dysplasia, but how would you identify them? You can use your clinical parameters, radiological parameters, as well as morphological parameters. Clinical parameters is a J sign, which indicates insufficient MPFL in a patient, and very important to look for this mid-flexion instability, where even after flexing above 40 degree, there is the patella can be easily subluxated out of the groove. So that indicates significant trochlear dysplasia. The other reason for mid-flexion instability would be patella alta. Because of the long tendon, the patella fails to engage into the groove. The radiological parameters, the sulcus angle, which is the angle between the medial and the lateral face of the trochlea, is abnormal if it's more than 145 degree. That indicates that trochlear dysplasia may be needed in these patients. And another parameter to assess the lateral trochlear support would be the lateral trochlear inclination, which is the angle between the lateral facet of the trochlea with the posterior condylar line. Once again, if it's more than 11 degree, it is less than 11 degree, it is considered to be abnormal. And morphologically, if you're looking at MRI or CT and you're looking at this bump or a cliff pattern, these two patterns indicate that the patient is having a severe significant trochlear dysplasia, and that needs to be addressed in the patient. There are so many techniques that have been described. De Jure has come with the deepening trochleoplasty, and Breiter has described thin flap trochleoplasty, which can be done arthroscopically. And there is a proximal grooveplasty, which guides the patella into the groove, which is indicated in type B dysplasia, and bedate lateral lengthening trochleoplasty has also been described in certain select cases where there is a shortened lateral trochlear facet. We have not had any experience in these procedures. And let me go through illustrated case example where we have done a trochleoplasty here. And this is a 24-year-old female with multiple dislocations. And as you can see in this MRI, there is a bump-shaped proximal trochlea there. And even though the distal trochlea looks okay, but the patient has significant mid-flexion instability. So with this new devices and implants, we can do the trochleoplasty with a minimally invasive approach. So we go through a lateral approach where I lengthen the lateral retinaculum so that we can do Z lengthening later. And at the margin of the cartilage in the bone, we mark using osteotomy, and the new groove is also marked. And these are the devices from Arthrex, so which is used a burr with a jig. We have two offset burrs, 3 mm and 5 mm. So these burrs are used to raise a 5 mm thick cartilage, and the handle can be used to deepen the groove under the flap, and also the central portion of the trochlea is flattened, and then it's molded and a new groove is created, and then it's stabilized with the multiple suture anchors. You can see the first suture anchor is going onto the top portion of the notch, and then the vital sutures are taken and fixed along the groove onto the proximal portion, and the sutures from the first and second anchors are loaded and fixed to the third anchor. As you can see now, there is a good amount of mid-flexion stability, and the lateral retinaculum has been lengthened. Even without doing an MPFL reconstruction, we are able to achieve a very good stability. And after this trochleoplasty and MPFL reconstruction, as you can see, has also been done in this patient. So this is the outcome, the postoperative CT scan and the stability. And these patients, because of the vicral sutures, will have some amount of crepitus for a few months, which goes away with time. So this is a post-op outcome showing a good stability and good functional return to normal life. Once again, these are the indications for different varieties of trochleoplasty. Patelloplasty, Dr. Raju has asked me to talk. We don't have any experience, but I think for completion's sake, I want to mention it. It is a procedure where you modify the patella to shoot the trochlea. We had no experience with it, but this is from the literature. In case you are coming with a oddly shaped patella like this, you can do a reshaping of the patella. So this is the patelloplasty from the literature. To conclude, trochleoplasty is a very rewarding procedure. It's very much indicated in patients who have apprehension and instability more than 40 degrees, especially the mid-flexion instability. Trochleoplasty is indicated in type B, C, and D varieties of trochlear dysplasia with sulcus angle more than 140 degrees and lateral trochlear inclination less than 11 degrees. And it's very important to rule out patellofemoral osteoarthritis and rotational malal ailments in these patients. Thank you very much for your attention.
Thank you so much, Clement. It's an amazing talk, and the key message that I got from this talk was just like in a tibial tubercle osteotomy, when you distalize, you automatically medialize by a few millimeters. Similarly, you reiterated that when you do a trochleoplasty, there is an automatic reduction in the TTTG groove distance. My question to you, Clement, is how do you decide where to mark the new trochlear groove line? Do you use any objective intra-op criteria, or is it just an accurate visual guesstimate that you use?
It is it's a guesstimate only, because you have a bump like this, and you'll also you can assess the previous groove. Okay, so normally if you have a TTTG distance is increased, probably you would want to create a new groove 8 to 9 millimeter lateral to the whatever groove-like thing you see there. So it's mostly a guesstimate.
Tried using vicryl tapes? Are they easily available instead of the vicryl suture? Because there's a concern of point loading of the cartilage by those sutures.
Yeah, I have not been able to get vicryl tapes here. So I use number 1, 3 sutures of number 1 vicryl and load them.
So, Raju, I use suture tape, and I haven't had any problems for doing trochleoplasty using suture tape. So it works.
Which kind of suture tape, Bhushan? Vicryl tape?
Suture tape 2 millimeter, the suture tape mini 2 millimeter. So
Okay.
it works quite well to use that. Can I ask something to Clement? So
Yes,
Clement, that
Bhushan.
was a good case presentation you showed just now. Now, I think Ronald would also want to, I also want your opinion. Would you have done a derotation along with the trochleoplasty in this patient? Because she also had significant intorsion of the femur if you saw the CT. Of course, we haven't got the hip to compare, but, and there are also a bit of valgus. So would you have done valgus correction and derotation along with trochleoplasty? I would have just done a bumpectomy, but I just want your opinion and Ronald's opinion.
I also agree that there is a bit of internal rotation on the femur, but if you look at the other knee also, a similar internal rotation can be found. So many times in people like this girl with the low demands, we try to fill up only the missing link. So what has gone wrong with her? What kind of minimal support I can give to her? So many times I'll show another case also in the discussion. So in this patient, probably I thought the proximal bund can be taken care and guide the patella into the trochlea, create a good support and add MPFL. That should be sufficient for her demands. Probably she may have a similar internal rotation on the other side also. But I just try to fill the missing link, why she has developed instability in this patient, what are the pathoanatomy, try to correct it so that we can restore the functional to a reasonable level. So acceptable what you were telling in the last meeting.
Got it.
Philosophy.
Okay. Ronald, do you want to comment on that?
Yeah, first of all, you need the proximal femoral slides too. So you have to have them to diagnose an additional rotational. I saw the valgus too, and I agree with excellent presentation of Clement on this topic. He makes it look so easy. I have done not many of these procedures, but it wasn't easy in my hands. I can tell you that. And the other thing on this topic is, so to answer your question, Bhushan, I would correct every factor if the patient is up to that. But my patients are a little bit younger than probably this lady was. So you can go for the strongest in your hand and do only one of the factors, and you can get away with it probably. In my practice, I see bumps also in these patients. However, what I also see are these flat patellas. And even if I have MRI scans available, I see no V shape of the patella if I have a bump in the femur. So why would I then create a V shape in a trochleoplasty to accommodate for a flat patella surface? And I don't see many indications in my populations to do a trochleoplasty, to be honest. But of course, I have a very weird population. I have these combined things. So yes, probably if that is exactly the only pathology, I would go for a trochleoplasty. If it's combined with others, I would first do the bony factors, and then in the end, probably, if nothing helps, correct a trochlea with a trochleoplasty if I have a V-shaped patella to go with that. If it doesn't fit, it will never fit.
Yeah, I have two questions, Clement. One is a very basic question for you, and the second is a more of a generic question to all the four panelists. So the first question, Clement, you spoke about that classification where you said about the proximal entry and lateral support. Can you just elaborate a bit on that? What do you mean by a proximal entry, and what is the lateral support? So what do you do exactly with these two words in that particular classification?
Basically, it means that you should not get carried away by a normal looking sulcus angle and lateral trochlear inclination. Many times, especially beginners, you tend to look at the distal trochlea on the MRI, look at the V shape and say, okay, the trochlea looks normal. But the trochlea, the patellar dislocate starts a little higher than that. So normally when you go up, when you exactly start seeing the patella, you will find the bump there. So even though the distal trochlea may be normal, the bump kind of pushes the patella out. So that's what I wanted to emphasize, because there are two components. Just because distal trochlea looks normal in your MRI or CT scan, you should not miss seeing the top portion, because the bump lies above the trochlea. That's that's very important. Otherwise, now the second thing is how these features like the bump and other things cause the radiological findings. That also we want to correlate rather than going by a cross-sectional MRI or CT scan alone. So my emphasis on understanding these things and looking for them in a properly done lateral X-ray, which gives much more information than an MRI or CTs.
Okay, so the question to all the panelists, and Dr. Ronald alluded to it a little bit on trochleoplasty. So the question is that, generally speaking, what we hear is that trochleoplasty is a difficult surgery and it's very rarely required, and there are other ways to get around it. So I just wanted to ask Bhushan, Ronald, Raghbir, and Clement, what are your thoughts? Is there a big role for trochleoplasty? Because to be honest, I haven't done a single one yet, and maybe I'm missing something. So, but you occasionally hear at conferences that that's not necessary, and there are other ways to go around it. So we'll start with Bhushan. So what are your thoughts on this statement I made, and how do you?
What you asked is exactly what my feelings were. Let's just say I'm a recent convert to trochleoplasty. I just bit the bullet and started doing it last year, and it has been really rewarding to do trochleoplasty. I realized I was worried for no reason. I was always worried about chondral flap necrosis and developing severe osteoarthritis in the patellofemoral joint if my flap was too thin. I don't even use the jigs that Clement showed. I just use a sharp curved osteotome to scrape out all the bone from under the flap. You can even cut the flap in your new groove that you want to create and push it using a plastic pusher and fix it using a couple of anchors touch wood, I haven't had any issues. This all started when I was doing a derotation osteotomy, and despite doing a good derotation osteotomy, I wasn't getting the perfect tracking. And the reason for that was a big bump. So I did a bumpectomy. I remember Sachin had shown one bumpectomy in last PKC, and I was quite impressed with that. So I did a bumpectomy, and still the patellar tracking wasn't up to the mark. So I did a trochleoplasty, and voila, everything just went perfectly well. So I'm still slightly hesitant in offering that to everyone. But anyone with a cliff kind of trochlea, I think it's a good option. But again, we are all essentially trained to look at the alignment first. So once the alignment is sorted, trochleoplasty comes into picture in my book.
Yeah, thanks. Raghbir?
Yeah, so I'm in a very similar boat to you, Parag, in that, I have a lot of patients and that I work closely with, Ronald, and we sort of see loads of these, particularly young ladies coming in with these miserable malalignment syndromes, and typically by correcting the rotational malalignment, making sure that the soft tissues are all are in where they should be, we tend not to have to see much of them requiring trochleoplasty. In fact, in the sort of 5 years I've been working with Ronald, it's a very rare occurrence. I've started a similar practice in my National Health Service, and I've done perhaps about 7 or 8 of these cases now, and they've all done, touch wood, they've done well with getting that rotation correct. So Bhushan used the analogy, and I frequently use it for medical students. You've got to get the train on top of the train tracks. And if the train is running on the train tracks, so the patella on the trochlea, that's usually sufficient. I'm sure as I look harder, I'll start to find patients that Clement has nicely pointed out today, but perhaps they're 1 a year, something like that. So it's a very low volume in my practice.
Right. Dr. Ronald?
Yeah, well, I'm very much intrigued by the presentation of Clement, and especially by that slide of the bowling alley. It will stay in my mind for the next days. I'm pretty sure of that. Yes, maybe I should go back, look a little bit harder, and look a little bit better. But again, I think we all have different practices. And if you're more into sports medicine, you will more have the patellar instability. If you are more into the bone surgeries, you are more getting the rotationals. And probably you will see them all, both, and I will miss some of these, so they may have seen me. But yeah, I will study again, Clement. Thank you very much for your great presentation. And maybe I should reconsider it. And Bhushan, I think your approach is very good. Don't stick to what you were aiming for, and if you're able at the same surgery to add, to do the bumpectomy and then go further to do the trochleoplasty, whether it's in one session or in different sessions afterwards, I think you're going for the best result of your patient. Yeah.
Perfect. Clement, your concluding comments on my question?
Yes, sir. I think you have to look for the significant trochlear dysplasia, and you have to match with the patient's need. And in our Indian scenario, you will find a lot of rotational deformities which may need big surgeries. But sometimes I explain to them, you have these problems, but can we get away with something simple like a stopgap? Because in India, our patients after surgery, they don't put take it to the limit. They always restrict their activities. And we have done so many MPFLs from 2000 to 10, ignoring all the trochlea, they have been working well. But now what I'm doing is I try to advise, educate them. If it is a significant trochlear dysplasia, and I try to do only this for him. I'll show a case in discussion where he had a syndromic bilateral patellar dysplasia, where on one side I went all out for 5 procedures. On the right side, he is a national level football player. He had only one or two dislocations. The last one was 3 years ago, but he had all the internal rotation of the femur, the patella instability near extension, but the patella is not dislocated for the last 3 years. So I got away with just an MPFL reconstruction alone. So we'll see that case if there is a time later. So in significant cases, people who are likely to fail MPFL, probably I would advise trochlear dysplasias.
Okay.
Clement, there is a question for you in the chat box, and in fact, this is what I wanted to ask you myself, and this is what I observed in a very short period of time I spent with Professor David Dijur. Our delegate, Mr. Siddiqui, Dr. Siddiqui asks that de jure advises trochleoplasty for a type B and type D trochlea. At least at that point in time, he was doing trochleoplasty for these two type of trochleas only. But I think with your concept of proximal and distal entry and support, there are indications for type C as well. So what is your current, if you can simplify your thinking for trochleoplasty, what would you advise our delegates and panel?
The classic indications should be type B and D, right, Raju?
Yes.
Yeah. Type C is most difficult. Sometimes I used to do the guttural recession trochleoplasty, where I just push the bump backwards, remove a triangular piece of wedge from behind the bump, and push it backwards and fix it so that I just make it flat. I don't create a groove or something. So that is one option we can advise in type C. All trochleoplasties I have done are type B and type D. Type C, I have done at least one case with the recession trochleoplasty.
So one quick question on, does anybody in the panel do patelloplasties? Because I feel that's more of like a bailout surgery or a damage control surgery. I don't know. Does anybody have experience in doing it? And can anybody in the panel make a comment on patelloplasties? Yeah, Ronald.
Yeah, well, I've in like 15 years or even more, I've done two, and just to make a V shape, it's not too hard. If you have a good clamp, you can compress it. You put two screws, and it's done. So it's not very shocking kind of surgery. I wasn't like very impressed on. Yes, it fits better, but on the result as regards pain reduction in these patients. Stability, yes. Pain reduction, no. And it's often the combination patients come with. So I think worldwide there aren't many doctors who do these. And we should have better scientific proof probably on when to do that.
Okay, thank you.
I guess patelloplasty will remain a controversial topic, be it in sports medicine or in arthroplasty. So our president's views would have been very interesting on the same. So I think the three talks have concluded very well, and we are looking very eagerly for the panel discussion. I'll hand it over to my friend Bhushan to lead the panel discussion, and we'll have case presentations. Bhushan, your panelists are Dr. Ronald, Clement, and Raghbir.
Okay. What I'm going to do is I'm just going to show one case first, and we'll steer the discussion based on the case. So it will be very easy to chat about specific topic. Is that okay? Okay, Raju?
Yeah, and please keep in mind that Raghbir and Clement have one case each to present.
Yeah. So I'll just show one case first, and then I'll ask Rax to present, and we'll ask questions while we are discussing case. It makes it more interesting rather than have a theoretical discussion. So let me just share my screen. Okay, so continuing what we discussed, you have to find the cause and fix the cause. You often come across cases such as this. This is a 16-year-old guy, fairly fit and active, recurrent patellar instability, has had, I think, a couple of surgeries till now. The last one was a failed Campbell's procedure. So someone went really full throttle inside, did a massive lateral release and did a massive medial plication. But as it happens, what is important not to miss is why the patella is not engaging in the trochlea, and this is what we've been discussing for last 1.5 hours. It's about why the patella is not engaging in the trochlea. The patella height is a very important parameter that often is not considered. We hear about surgeons doing medialization, but not much is made about distalization of patella to correct the patella alta. So this patient is again coming to my same old dialogue of was in a zone of acceptable malalignment. There is about 15 degrees of intorsion on the femoral side. He was only 16. He had a type B trochlea. The MPFL had gone, and I didn't want to do anything more than what has been done till now. So what were the options at that stage? I'm not going to show any more MRI, so I'll just stick to this just now. So I could have just done a repeat of what was done before application and release. Could have gone for a trochleoplasty plus minus MPFL. It might have worked. But mind you, the patella is not engaging in the trochlea. The dislocation happens in first 20 degrees of flexion. So from extension 0 to 20 degrees of flexion, the patella is maximally unstable. Or I can do a tibial tubercle distalization plus minus minor medialization. The TTT distance was about 18 millimeters in him, and an MPFL reconstruction. This is how he looked. I'm sorry, I'll come to that. So the reason I'm showing you a simple tibial tubercle transfer is that what is missed by most, of course, not experienced people like you here, is that the whole tibial tubercle has to be elevated. So by doing an osteotomy such as this, you can't just shift the distal part of the tibial tubercle medially and say that you have done a distalization. What needs to be done is this. The whole tibial tubercle has to be lifted off from the tibia. So it has to be released both laterally and medially and physically shifted distally by 2 millimeters. So that's me using a bone cutter to take out 8 millimeters of the distal part of the tibial tubercle and fixing it. Yes. So that's what you need to see. You need to see the whole tibial tubercle lifted off. The tibial tubercle should be, you should be able to pull it distally along with the patellar apparatus comfortably, and there should not be any adhesion stopping it from happening. So if you can see here, that's about 8 millimeter distalization of the tibial tubercle. And going back to the same discussion, you always need to add an MPFL reconstruction to it. So that's a standard MPFL reconstruction that I do using 2 anchors on the patella and a screw on the femoral side. That's how it looks when it's properly placed extrasynovially. You can see the nice V-shaped impression inside, and that's him about 6 months post-op. So you can see the old scar from the Campbell's procedure. That's he's 17 now after the surgery. I'm just showing him what to do, and you can see he's worked well on his knee. He's able to do most of his activities normally. The alignment, as I said, is not bad. He's not having significant intorsion, and he's able to do this at 6 months, and he wants to pursue a career in football, which is amazing for someone at his age, for someone who was told that he won't be able to walk long distances due to his patellar instability. So it's an important lesson for me that not everyone needs a massive derotation or something like that. Sometimes a simple thing such as distalization of patella alta to get the patella engaging early on in the groove is all that is required when there is type B or just a shallow or slightly deformed trochlea. So that's something which I want to bring on to the panel. So let's ask some questions. Give me a second. Okay, so Rags, what is your cutoff limit for shifting, correcting a patella alta?
Yeah, so I use the patella trochlea index, so on the MRI scan. So I think in my practice, having a MRI scan is quite important because you really get a good idea. We used to use the different measurements of using the full patella height, patella tendon, but my main criteria is looking at how much of the overlap there is, and that helps me to decide just how much to distalize. Typically, it's associated with the medialization of the tuberosity as well. But typically the MRI scan helps me to dictate that. Okay, can you just elaborate what is the patellotrochlear index and how it shows the engagement or how it implies the engagement of the patella? Yeah, of course. Yeah, so it's all dependent on the position the MRI scan's taken. Typically, it's in an extension. You're looking at the degree of the cartilage contact between the patella on the trochlea. So you're measuring the distance or the combined distance of the overlap as well as the overall distance of the patella. So if it's high, it's a low overlap, a reduced overlap, and if it's obviously engaged, that's sufficient for us. So that's the typical MRI findings. Okay. Clement, do you often do tibial tubercle distalization in your practice? And if you do it, do you combine that with trochleoplasty when you're doing a trochleoplasty?
It depends. I do dislocations based on clinical parameter like midflexion instability. Patella is not engaging beyond 30-40 degree. And then the trochlea is normal. Probably I will just do an MPFL and a tibial tuberosity dislocation and medialization. In few cases, maybe I would say one or recently we have done all three together: tibial tuberosity, trochleoplasty. I will be showing that case also. So the clinical midflexion instability and radiological parameters like CD ratio, insult salvity, and the TTTG distance all combined together. I often do it.
Okay, Ronald, what's your take on distalization of the patella or tibial tubercle for getting correction of patella alta?
Yeah, I think it's a very powerful instrument, the distalization. And I'm undoing a lot of MPFL reconstructions these days, so I'm not a big fan of that. That is because, at least in my country, in the population I see, there are a lot of pain complaints by overdoing your MPFL, and that has to do probably with not a good technique. And in your hands, it's such an easy tool, and you can address it correctly. But I see a lot of downsides of MPFL reconstructions these days, and specifically in these patients who had a patella alta to begin with. So imagine that you do not correct that, do just an MPFL. There cannot be a normal isometric or any kind of range of motion to that MPFL-plasty. So tuberosity distalization, definitely, it's a very powerful instrument, and often it's the only thing I do, and I do not add anything else. And just one small detail, you excellently showed me, and I do exactly the same. I cut off something, I cut the whole tuberosity off. A detail there is, if you have cut the bone and it still doesn't want to go down, just go with electrocautery, medial as well as lateral, besides the patellar tendon, because there are small vessels and very strict structures there that may prevent you from distalization. So cauterize these because there are bleeders there, and then it's fully mobile as you showed. So that was an excellent presentation.
Okay, so one more tip is that most of us, or all of us, want to go minimally invasive, and I've seen a lot of colleagues doing a small incision that big to do a tibial tubercle distalization or transfer. But what essentially happens, you just move the distal part of the tuberosity to one side or pull it down without changing the anatomy proximally where it matters. So it's important to release everything. And on the lateral side, there is a big attachment of ITB. Quite a few times, if your angle is not perfect, you are going into Gerdy's tubercle, and then you almost find it impossible to move the tibial tubercle because it's also connected to your ITB. So make sure you release it completely on the lateral side. That's the only condition, only procedure where I do a massive lateral release along with that. Maybe I should think of doing a Z lengthening along with, rather than just doing a lateral release. Rags, do you have a case, or Clement, do you have a case to show? Sorry.
I have one question, Bhushan.
Yeah.
One quick question on this, not directly related, but since I also do a lot of joint replacement surgeries, knee replacements, and many times I see cases which have a patella alta. So do you have any recommendations that while doing a knee replacement, does that patella alta need to be dealt with? Do you need to address it by doing, the distalization, what you said, or are there any other ways like you proximalize the joint line or something? So any thoughts on this?
So I don't have that much of experience of joint replacements where I'm doing anything in tibial tubercle. I do a bit of revision work where I generally, whenever I'm struggling to evert patella, I do a tibial tubercle osteotomy, and more commonly than ever, I pull it down very slightly by 2 or 3 millimeters to get the patella engaging properly. I'm still not a fan of doing a patella replacement when I'm doing a TKR, but if I'm struggling, I would use a smaller button and maybe place it distally on the native patella. Any more thoughts, guys, on that, Clement and Rags?
Mine is only during a revision arthroplasty, and it's an interesting concept that we're talking about here. You know, these patellofemoral osteoarthritis patients, are these the beginnings of the patients that we're seeing in their teenage years where they've got this patellofemoral malalignment and they go on to require the arthroplasty and making that a difficult primary procedure as well as obviously revision setting. So I think it's a very important topic to be discussing here, because I suspect the pathology we're managing now will hopefully offset what the future may entail for that patient.
One question to all the panelists about the simple basic MPFL reconstruction. There was a lot of talk about MPTL reconstruction. So any experience about MPTL? So MPFL plus MPTL as a combined procedure? Anyone or any experience of that? There's a lot of papers about using a ligament to the tibial side also. No idea.
I've done 2 cases.
Okay, yeah, go ahead. I don't have
that was for a 10-year-old kid, so I couldn't do any bony procedures. It was an obligatory dislocation with a patellar hypoplasia. So we did MPFL soft tissue based without drilling, and I also added a MPTL arm also, so that I thought it will work for up to 3 years until he gains maturity. So I did one, and the second patient was 19-year-old medical student, and she was a classical case of a trochlear dysplasia, but it was a long time back. The father was a cardiologist, a lot of orthopedics, and so to do something minimal. But that time, I didn't know how to do trochleoplasty. We didn't have all the jigs and such. So I told them same thing. So we'll just put a missing link, put a strong ligament. I did a MPFL double bundle and an MPTL using Sancheti, and it is now 11 years now. Follow up. She's okay. Some crepitus is there. She may have a patellofemoral OA, but I offered her now that I have a capacity to do trochleoplasty, knowledge, everything, but she's not willing now. So these are the 2 cases where I managed severe cases with both MPFL and MPTL.
Excellent. Okay, let's have cases from any of you, or I can show one more case if you want.
I can present a case.
Raghbir is, yeah, Raghbir can.
I'll present a real quick case, guys.
Okay.
Sure. All right, gentlemen, so there we go. So I've actually got 2 cases, but I'm just going to show one quick one. So can you see my screen?
Yeah.
Perfect. So we're just going to talk about miserable malalignment. And these are cases I've done with Ronald and Adrian. So I'm just going to skip to the second one first. So this is a patient who's 25 years of age, presenting with anterior knee pain, recurrent patellar dislocations with multiple opinions. That should say MPFL offered each time, but she wanted to come and get an opinion from us. As you can see from the clinical examination, feet are pointing forwards and her patella is pointing inwards. So this is a typical presentation one might see. It's really useful examining them on their fronts and you assessing their rotational profile. And just from here, you can see this is a good idea of excessive femoral anteversion, and looking down from the top up. This doesn't completely give the full picture, but the excessive tibial torsion. I also took a video of the way that the patella was tracking, and you can see here nicely on both sides as this young lady goes into full extension, the patella subluxes laterally, so the typically referred to as the inverted J sign. So I've got some cross-sectional imaging done, and you can see internally rotated at the femoral neck and massively internally rotated at the distal femur. Sadly, I don't have much cross-sectional imaging at the patella, but you could just see the patella sitting very laterally in this case. The proximal tibia, you can see 22.1 at the proximal tibia internal rotation and a 25.7 degree external rotation. So the pathology essentially is a recurrent patellar dislocations with internally rotated femur, externally rotated tibia, patella alta based on the MRI scans with an increased TTTG offset and reduced and a patellar trochlear index. So the options. Options she's already had: physiotherapy. It's all in your mind. Go and see a psychiatrist. Don't come and see me. Physiotherapy, bracing. Not really good options here. Ronald's phrase I always use is the bone always wins. So an MPFL reconstruction is not going to be an option. Is a double derotation simply going to be enough? We've had a really good discussion just now about all the other small elements and correcting everything at the same time. So I'll quickly go into what I did. This what was done. This is one of my post-ops that Ronald advised me on preoperatively. She's gone on to have a double derotational osteotomy with a tibiotubercle distalization and medialization. The new things that I've learned recently, been doing a lot more, is putting these staples in the front to get some compression. And on the tibial side, I use a compression staple also. She was absolutely tiny, this young lady, and these plates look absolutely massive on her. But I was able to achieve the rotation that I wanted and compress at the tibial tubercle. So I guess my question to the rest of the panel is, would you guys have done anything differently or have any thoughts on how you would have managed such a patient? Bhushan, I'll go with you first.
And I think you need to be a bit brave to do a double derotation by yourself. It's excellent if you are two surgeons working together, makes life much easier. But yes, I think what you did was perfect. If you had just done a derotation on the femoral side, she would ended up with a massive tibial external rotation deformity with a Charlie Chaplin-like gait, and she wouldn't have been happy. So I think that is the minimum that you could do. Did you do an MPFL as well? I forgot to ask, sorry.
Yes, I forgot to I also mentioned, I didn't do an MPFL. What I did was a lateral lengthening and a medial plication. And actually, you know, I've seen that with Ronald a few times now, and I did this just a couple of weeks ago, and I have to say it's incredibly satisfying. We know that a lateral release shown by Amos's papers they can actually they can add to the problem. So actually doing a lateral lengthening allows you to have that stabilization by releasing the tightness on the lateral side. And also the medial plication, if you haven't seen it before, is a very nice procedure. You do a subperiosteal dissection on top of the patella, almost coming to the equator point. You do a reef of the medial structures, and once you've created a pocket in that subperiosteal dissection of the patella, you tuck those medial structures into that pocket. And, you know, Ronald's shown me that a few times now, and I've taken it into my sort of NHS practice. And so far, so good. So it's a nice, and that's particularly useful in the immature skeleton where you do not want to disrupt the growth plates. Ronald, you helped me before the case, and I haven't shown you the post-op images. What do you think? I'd welcome your critique.
2 words. I'm proud. Really, you did every step, and you explained it perfectly. I think this is the whole picture. And maybe to add one little thing to the reefingplasty, which has become unpopular in the past and now maybe deserves some more attention as compared to the MPFL. I do not do MPFLs too many times. I think it's hard with a structure which is not the structure that belongs there to make a new MPFL. I feel comfortable, and you know that step is very important in a reefingplasty to test it, to test the strength of your reefingplasty and the tightness. And you can adapt to that by putting your sutures and making your knots under a specific tension and not too much. And I think it accommodates easier for the patient than the check crane of the MPFL, which in experienced hands like Bhushan works, but in many other hands it doesn't work at all. So thank you for this great case.
Thank you. That's great. Clement, would you have done anything different, or do you think that's, would you have any comments?
Me?
Yeah, Clement,
I don't know. Yeah, sorry. I know it's too much for me. I don't have exposure in this complex osteotomies. Probably I would have referred to Bhushan in India. That's the best thing
I don't have that luxury. Thank you, guys. That's my case done. Thanks for the time. Appreciate it.
Okay. I think Rags, you have to leave now, is it?
No, he has a second case. You want to quickly go through
That's
that
okay,
case?
guys. I'll let Clement present. So that's fine.
Okay.
That's a very similar case. Thank you.
Okay.
Clement, go ahead with your case.
So I'm going to present complex bilateral patellar instability. Sorry, I'm just. So 19-year-old boy who plays football at a high level, that is his career, has been having recurrent patellar dislocation on both knees, and left side being more symptomatic. On the right side, he had last dislocation around 3 years ago. Overall, 2 dislocations on the right side and more than 5 on the left side. On examination, he had lateral apprehension. The J sign was positive. He had tenderness over medial joint line, and flexion was full, range of movement was full. So these were the MRI. And as you can see, he also had an avulsion fracture on the medial aspect of the patella, superior medial aspect of the patella. And the patella height was normal, and it was and clinically it was dislocating beyond 30 degrees. That is, mid-flexion instability was also positive. Here you can see the nice bump here, and you can see a hypoplastic medial femoral condyle. And as you come distally, you're having more of a flat trochlea. There is no sulcus or lateral support in this patient. And then he was subjected to the CT scan. We found out the TTTD distance was around 22, 23 millimeter. There was no patellar ultra, and we classified him as a type D trochlear dysplasia. And he was also subjected to rotational assessment. I refer to my joint deformity colleagues. So they assessed him, and they were okay with that. So this is how the arthroscopy was looking at. So this is view from the superolateral portal, and these are the clinical videos. You can see there is a prominent tilt. There is also a J sign as being positive, and this is what is looking under anesthesia. Even at 70 degree, it is slipping out. So this is tibial tuberosity, how it looks clinically. Bhushan, Raghbir, any thoughts? What would you offer for this patient?
So I think Rags has left. Is there any valgus in the knee on
No.
scanogram, Clement?
No valgus, Bhushan.
Yeah, okay. I think a derotation along with a trochleoplasty sounds to be a good option for someone like him in my hands. There's no significant patella alta as well. So I would plus minus a tibial tubercle as well. But I think those are the things which is a complex deformity, as you can see. The trochlear bump needs to be excised, and maybe rotation has to be assessed as well.
Yeah, so sorry. So I'll just show what we have done here. This is the view from the superolateral portal, and we started with, I didn't have an idea about the rotations. So we went ahead with the trochleoplasty. This is it lengthening of the lateral retinaculum being split in 2 layers. And at around 2 centimeters, we make the deep cut. So this is a deep layer of retinaculum being cut here. And then you open the joint. There's a synovium. And here you can see the bump. So we put K-wires, the supratrochlear area for traction. So the exposure of the cartilage bone junction, thin flap being raised, and same steps. So the new groove is being fixed here. It's a lateral flap repair. The flap is closed with periosteal sutures. So even after having done, you can see a significant tilt was there, and we went ahead and did a tibial tuberosity transfer as well. And then we did an MPFL reconstruction also, along with the VMO advancement in this patient, because he had this avulsion fracture which was excised, and the VMO was advanced to the. So this is a post-operative X-ray of the patient. And this is a functional outcome. He has full range of movement. You can also see on the right side, which he had the last dislocation around 3 years ago, and he was able to play very high level of football with this right knee even before surgery. I didn't want to do anything extraordinary because he had the similar findings, trochlear dysplasia, everything was there. But I explained to the patients this because it was not giving rise to any symptoms. Is comfortable playing even with this problem. So I'll just add a little bit of strength to the medial side, and I didn't do anything except doing MPFL reconstruction here and the lateral Z lengthening. So both the knees are doing well so far. Maybe next year he'll be able to go. What do you think, Bhushan, Raju, about?
No, this is brilliant, brilliant. So when you're doing your trochleoplasty, Clement, are you by changing the rotation of changing the alignment of the trochlea, are you also achieving some derotation? That's what I feel, because this looks brilliant.
So basically we do two things. Yeah, basically we are pushing the bump backwards by doing that. Under the flap we are removing the bone, so when you tighten, we are not only creating a groove, the proximal bump also disappears, so that guidance of the trochlea is established. And then because you are deepening the central portion, we are also having a good lateral support. In that way,
proximal entry also becomes easy, and then the passage through the main trochlea also is easier because of the bump excision and your trochleoplasty.
Yeah, I want to ask Bhushan also. I will show next case. Maybe I'll ask the question after that. This is not a surgery which I have done. Waiting for treatment. She's a very close relative of my orthopedic colleague. She had 5 dislocations, a medical student, 21 years. She walks with the intoing gait, but mild, I would say. No midflexion instability, not even apprehension when you test for apprehension. And when you do the assessment, this is how the proximal trochlea looks like on both sides, and the distal trochlea here, and TTTG distance was around 26 millimeter. CT rotational assessment is yet to be done. We saw her last week only. And so what is interesting is this CT scan, 3D reconstruction. Here you can see the entire trochlea is facing away. The patella is in line with the tibial tuberosity, which is much more lateralized. And we have digitally subtracted the patella here. Now you can see that the trochlea is facing out like this, and the tibial tuberosity is facing this way. And these are the videos to show how. I want to ask everyone, including Ronald, what would you do with this patient? Because on one hand, you have to look at the disability. Hardly 1 dislocation per year. If the knee doesn't dislocate, it's quite okay. There is no day-to-day disturbance, but appears to have a lot of rotational problems. So what would you offer this patient? How would you plan? Bhushan, Ronald?
Okay, I'll let Ronald talk first. Let him be.
Well, very nicely illustrated case. That patella seems to feel at home at that position with that little dislocations. However, on just riding on the ridge, you're bound to have more problems in the future, whether it's overstressed problems, pain, osteoarthritis in the end of the game. I would just, you have a TTTG that's massive off normal. You are the expert on evaluating the trochlea. Whether you can go without any rotation, correction of the femur, rotating that trochlea underneath the patella, I'm not sure, but you, as I got it right, you are still in the phase of evaluating the CT rotation profile. I really would like to see these values too. And then if you want to do it staged, go first to rotate the femur if there's a rotational deformity and do the tuberosity transfer.
Okay.
Probably second stage, go for your trochlea procedure. That would be my setup.
Okay. If she's okay with that intowing, and is it okay to just bring the patella to the groove by doing a medialization of the tibial tuberosity? The patient doesn't want the intowing to be corrected.
Yeah, but
But it is a very less disabling pathology for her.
She is going to have early patellofemoral OA with the way the patella is sitting anyway.
Okay.
That's my main worry. And the trochlea is not that bad. So if you look at the trochlea,
Trochlea is okay.
This is quite good. So a derotation will be all that is required if it confirms, if it's confirmed on your rotational CT that the intorsion of femur is more than 20 degrees. All you need is just a 20 degrees derotation and she'll be absolutely fine.
Okay. But my point is, even if you do internal derotation of the distal femur, the tibia is going to move out, right? Then you have to add another derotation at the tibial tuberosity level for this patient. Right? Am I right, Bhushan?
Yeah. So plus the tibial tubercle as well.
Yeah.
So I think tibial tubercle mediation is required because you won't be changing the TTTG distance by doing a supratrochlear osteotomy. Then the same. Ronald, you agree?
Yeah, I totally agree. You should do a double level then. To go back, because you said the lady does, the patient likes to walk in towing. I'm never doing any osteotomy for cosmesis, if that's a point. But the main problem here is that patella tracking, and you can get the same kind of neutral to intowing gait back if that's what the patient wants by doing a double level rotation. But I would always correct to normal values because that's the best for the joint and the structures in the joint.
Okay.
Clement, do you have any more cases? Or do you have any cases?
That's all I have, Bhushan. Thanks. I'll stop sharing my screen.
Okay.
Thank you very much for your inputs, Bhushan, Dr. Ronald.
Okay.
So do we have time or are we wrapping up?
Bhushan, we have about 10 minutes more, so you can just show one case, and then the next 10 minutes we'll wind up. Ronald, is it okay to go 10 minutes more? Clement?
Yeah, it's fine. It's fine.
Okay, perfect.
Just give me a second. Let me just open my screen. I'm just opening my presentation. Give me a second.
No problem.
So continuing from that one. Yeah. So I'm sorry if I've shown these cases to some of my Indian colleagues. So life sometimes can be cruel, and this is a 23-year-old physiotherapist not working with me, was referred to me by someone. She's a below knee amputee. So she's had some accident at young age and she has had an amputation, which is a small stump, unfortunately. And she has had multiple episodes of patellar instability on the affected side. She's just managed to get a stump which is working properly for her, but she's unable to walk comfortably or climb stairs, which is part of her normal training and work because of her patellar instability. And she's had multiple falls. So that's her CT rotational profile. So if you look at the side, of course, there is wasting of muscles. There is less bone density as expected. And you can see the stump which is coming there now. So a good amount of muscle strength on the other side, but that's her rotation. So if I just get that perfect angle for me. So that's her level of interrotation. You can see a small bump there, and the patella is not engaging, and she's had multiple episodes of dislocation till now. And that's her. That's how she looks. That's how her leg looks. And You can see this typical appearance of a stump with small skin warts and skin swellings. Patella seems to be stable when it's engaging, but very difficult to do anything distal to the joint. I don't want to touch the stump at all because she's just managed to get a prosthesis which fits. So what I did was a standard derotation osteotomy along with a MPFL. I did not want to do a tibial tubercle distalization, tibial tubercle mobilization, because I don't want to give a new scar on the stump. That would have been disaster for someone like her. So that's my, unlike Ronald, who has those sophisticated metal things, in poor India, we cut our own paper and sterilize it and use it as a jig for correcting the angles. The only advantage of doing this is you can measure the diameter of the femur and cut half of that from the point of rotation. So you are exact in terms of where you want the rotation to be, rather than thinking how it should go. So I took 2 parallel wires and one where I want the wire to be, followed by this biplane osteotomy that I showed before. Then a standard standard horizontal osteotomy, which is parallel to the joint line, and a biplanar osteotomy. As I showed, the biplane is taken off, and that can be used as a graft for holding correcting the valgus deformity, not in her case. And you can see how difficult it is to control the distal fragment because there's nothing to hold. The whole leg just becomes floppy, and it becomes a difficult thing to control the leg. You can hold a stump and rotate it somehow, but it does give you a good, comfortable feeling. So this is not her X-ray, but I've just this is not her picture, but I just put it as an example of using this as a valgizing tool. So once you get an appropriate rotation corrected, you fix it with a normal standard plate. So that's the end of the surgery. I've added a MPFL reconstruction. That's her X-ray, just slight varization I've done. And that's her, I think, 6 months post-surgery. So she did go back to work as a physio, and now she's planning to go to Australia or UK for further training in MPT or something. So it's a slightly tricky situation, and you need to individualize your treatment every time you are confronted by someone. Now, my question is, this is for Ronald, would you do anything for the tibial extortion that we are causing by doing a derotation on the femur? Because I think we can adjust the stump accordingly to get adjust the prosthesis to get her gait normalized. And is there anything different you could have done or would have done?
No, definitely not. I think you made an excellent way of factors preoperatively. If you make any extra scar to the stump, that only can cause her to have difficulty walking afterwards with her prosthetic leg. I guess it's now stable. She was stabilized. I thought from the scan, this was an excellent example, probably also of a very tight lateral capsule, but in your investigation, your clinical investigation, you showed that it was kind of mobile, but it may have to do with the soft tissues there. I wouldn't have done anything different. I have had a couple of patients, below knee amputees through the years, and to me, the individual approach is most important there. These patients often can tell you exactly what they need, much better than any other patient, and just treat that factor, even if other factors are in your hand and in your skills that you can do. Don't overdo it, and weigh each and every scar you make in these amputee patients, because that's very important for their prosthetic fitting.
Clement, your take on something like this? Anything you would have done differently? Would you have done a trochleoplasty for her?
No, Bhushan, I don't have experience in this osteotomies, but I'm just taking the points from you over the last few webinars. That's what I think is well done. And I have to congratulate you for attempting such a thing, and also the trust the patient shown on you, because everybody in orthopedic community will say don't do anything unusual. When you talk about new things, there will be a lot of discouragement from a lot of people. So the patient's belief in you, that's what I appreciate. Well done. Probably I should start looking for the rotational deformities in my practice, and probably learn to correct them as well. But we have an excellent deformity correction team in our center, so that's one impediment for us, for me not to learn these things. I just refer to them. They do a fantastic work on lengthening and other things. So that's where I stop at trochleoplasty and don't go.
Parag, what do you want to say?
No, so I think excellently done. That is the thing. I agree with Clement. These are the things you just want to shy away from. You kind of say do physio and everything is fine. It's an amputee. You don't want to touch them. But I really feel that this webinar has been very enlightening to draw the attention of most of the orthopedic surgeons to these rotational deformities, and the way the whole webinar has been structured is really nice. So well done, Bhushan, on that case. Raju, do I have time for one quick question to Bhushan and Ronald? It's a little different question, but I thought I might quickly ask it and then we can conclude.
Of course, Dr. Parag. And before that, I think, Bhushan, your case, fantastic. I mean, you remind me of a quote by T.S. Eliot: only those who risk going too far can possibly find out how far one can go. I mean, this is a case which, as the other panel members said, most people would discourage you from. So very well done.
Great. Yeah. So one quick question. It's a little bit not related to this webinar, but in a way it is. I usually, have a very big fight with my pediatric orthopedic guys who have, when a patient, 12 years, 11 years old comes, who has a, J sign positive and only the patella is subluxating, there are no rotational deformities. So their approach to that case is don't do an MPFL. These guys don't believe in an MPFL, if I may, kind of cross the line. They feel that just do a soft tissue sleeve procedure, something like a complete medial release and plicate the whole thing, and a lateral release and a medial complete plication in one sleeve. So what are your thoughts, Ronald, and then Bhushan, you can answer. Do you also have these kind of difference of opinion with your pediatric guys, especially when you deal with the patellofemoral instability in these kind of age group? Yes, Ronald?
Yes, as Rex already stated, we do the medial plication and lateral Z lengthening in these underage patients, and that seems to work well. However, some of them have all the other issues too. So I always tell them, as well as the parents, of course, that this may be a temporary solution until they've grown up and all growth plates have closed. I do not feel very comfortable of having screws very near the growth plate if you would do an MVFL. So that's the reason why I would shy off from that. But I'm not experienced in MPFL, I have to tell you that.
Bhushan, thanks.
So, the youngest derotation I have done is a 15-year-old. That was just after confirming that everything had, all the fascial plates had closed. But I think for a 12 or 13-year-old, I would be quite hesitant to do anything apart from a simple MPFL. And the way I would do MPFL is like what Pranjal has described. So it's a soft tissue MPFL. You stitch it to the patellar periosteum and maybe stitch it with the periosteum near the medial epicondyle of the femur. Once again, it's most important to tell the patient, relatives, or parents actually, that this is a stopgap arrangement. This is going to fail most probably when he or she reaches, normally it's a she, when she reaches 16 or 17 and she will need a formal procedure. But I think we can't leave them without anything. It's impossible for a child to control his or her activities. And you see really bad results. So I have a patient who's I think 13, and I've done an MPFL reconstruction for him on one side, and his outlook has completely changed. So he was forced by his parents not to go out and play with his friends, and he's been depressed for about 1 year or so. And we do not take it seriously, children being depressed, but that seems to be a very serious thing. And his mom came to me about 3 months back and said, my son is completely different now. So it does make a change. I think even if it's a stopgap surgery for next 3 or 4 years, if they can have a normal childhood during that, I think it's worth going. That's what I would do for my son, or I guess you would do for your child as well.
Right. Great. Yeah, that answers my question. Thank you very much. Over to Raju.
Thank you for this very excellent discussion. Thanks, Bhushan, for moderating this session so well. And thanks to each of the speakers for contributing very actively. We'll have a very quick announcement from Dr. Parag, and then I'll conclude the program.
No, so just a quick announcement to all the viewers who are watching this program regarding the Society of Knee Surgeons of India membership. We have already about 220 members, and we plan to close the membership by end of this evening. So if anybody is interested, there is a link which we have sent to all the viewers on OrthoTV. So please, you have the opportunity to join the Society of Knee Surgeons of India. It's a very elite group. We have a membership by invitation, and after that, then we are planning a physical meeting next year for exclusively only for all the SKI members. So that is what I wanted to announce, Raju. And once again, thank you to all three of them. Lovely, lovely webinar. So much of learning. Thanks, Ronald. Thanks, Clement. Thanks, Bhushan. Over to Raju.
Thank you so much. And this indeed was a very eye-opening session. I mean, all the 3 sessions on osteotomy have been very good. But then looking at this session, it does seem as if rotational problems of the lower limb are the commonest disease affecting mankind. So it has really opened our eyes to how to look at these deformities in a scientific manner. And I think the key message is by Dr. Ronald, the bone always wins. So if it is crooked, you can't expect it to get corrected by just putting a soft tissue. And I think the other message that came across was that these surgeries are complex. So double level osteotomies of any kind probably need 2 well-trained osteotomy surgeons to complement each other's skills. So I think a word of restraint and caution is also advised. So I'd like to begin by thanking our SKI president, Dr. Ashok Rajgopal. I remember when these webinars were being discussed, he was the one who gave the idea of osteotomies around the knee as a joint preserving option. And I'd like to thank Dr. Parag for arranging such excellent faculty and coordinating so nicely for all these sessions. I mean, we've had key opinion leaders for each of these 3 sessions. And for this particular session, my thanks go to Dr. Bhushan, Dr. Clement, and of course, Dr. Ronald for accepting our kind invitation. Unfortunately, Dr. Sachin, who was due to moderate this session, could not attend due to some unforeseen circumstances. But the entire scientific program of this session in axial plane, coronal plane, and trochleoplasty was prepared by him. It was his brainchild. And I was also encouraged by Dr. Dinshaw to have an osteotomy session specifically on the patellofemoral joint. So many thanks to all the SKI executive. And last but definitely not the least, these excellent audio visuals and the behind the screen work is thanks to Dr. Ashok, Shyam. His untiring efforts ensure that we are able to watch this program live, and the recorded version will also be made available very soon through OrthoTV. And I'd like to thank all the SKI members and all the delegates who have participated very actively through all the 3 sessions and opened our eyes really to how osteotomy can make a difference in our patient's life. Thank you very much.
Thank you.